All right. Good morning, everybody. Thanks for jumping on Thursday in the summer. Hopefully, all of you guys have had an opportunity to get a little bit of a break, but if not, you have a few more weeks before the summer starts, before the summer ends and school starts. Hopefully, you'll get a little bit of a breather in. Here's our agenda for today. Start with some OMSAS updates. And we do have some special guests to talk a little bit about IBHS incentives and a value-based model upcoming, network updates, and some bunch of clinical updates, reminders, and things to review, and some projections of what's coming up in the future and some resources. So thank you again for joining and representing your agency and being able to pass along the information that we discussed today. Just as a reminder, the chat feature is disabled for this, but the Q&A is available, and we do have some people monitoring that. So if you have a question, you can feel free to put it in there, and they'll either interrupt in the middle or near the end as appropriate to get your questions answered. So not too many OMSAS updates. We haven't had an actual meeting with OMSAS and the BIMCOs since our last meeting. Had a few emails here and there, so I am going to sort of give you the overview again about the primary insurance issues. We did pass along, as I had said before, some collective feedback from all of the BIMCOs about TPL issues, working with primary insurances, some of the obstacles to getting to the Medicaid to be able to reimburse. So I had discussed that previously about all of the, different talking points that you guys have offered and collective again with the other BIMCOs. We do have an opportunity coming up. Magellan and another BIMCO are going to participate in a meeting with OMSAS and the Pennsylvania Insurance Bureau, just to, again, talk to those points. So maybe I'll have some more information or an update. In the meantime, continue to speak to us so that we have some of that information. And then there's also the formal complaint process, which I would encourage you guys to utilize or the families to utilize. So I did throw in a slide, a little bit of a bullet here about some of the information you should have if you're going to file that report, some of the things that they look for and ask when you do file that report based on some other providers who nicely shared some of that information. So this second bullet talks about some of the information that is good to have when you do that, or share again with the members or guardians if they're filing a direct complaint as well. So let's keep that conversation going, and I'll continue to give updates as I can. Other than that, I don't have any other state updates at this time. We do have, again, some special guests coming on to talk about IBHS incentives and a value-based model. So I will turn it over to Kristen Peak.
Thanks, Kristen. So some folks on this call may participate in other value-based models that we have. So you may be sort of familiar with how we do things. And for others of you, that might not be the case. Magellan is developing a value-based model for IBHS. And at least initially, we really want to focus on access as the kind of primary measure that we're looking at. So I'm going to give some very broad details today, and then I'll talk a little bit about what to expect in the coming weeks. So what we are going to be doing is including only some providers. And so we're going to have a cutoff for a minimum threshold of assessments that providers complete to be included in the model. And when we're looking at access, we're going to be measuring the number of new members with assessments, and then looking at the number of days between the end of the assessment and the first service that follows that assessment. So what we'll be doing in the next several weeks is reaching out to providers, and we will let you know whether or not you're included initially and why. I do want to call out that we are going to be reevaluating who's included on an annual basis. So if you are not included this year, we'll certainly be reevaluating again in 2027. And it's certainly possible that additional providers may be included at that time. Some providers who are included may receive a rate increase, and we will be sharing further details of that as well as specifics of the model with the included providers. And then after we start with the access measure and start looking at that, we will also be adding incentives based on case conceptualization. So that will be available in year 2 of the model. So I know this is a very broad overview. As I said, the providers who are included will be getting a lot more information in the coming weeks, and we'll be having a meeting with those providers. So for now, just be on the lookout for an email from us, probably me, letting you know whether or not you'll be included for the first year of the model. If you are not included in the first year, as I said, you can certainly be included in the future. We'll be evaluating on an annual basis. To be included, providers need to complete at least 25 individual or ABA initial assessments in the year. We are not including group services at this time, so it's just those 2 assessment types. And I'll just note that we are not including members who have commercial insurance. It's only members who just have Magellan. That's kind of a very broad overview. And as I said, we'll be reaching out with further details and letting folks know who's included and not in the coming weeks.
So I didn't see any questions pop in thus far, but again, you're going to give the providers individually a lot more information. So I'm sure they'll wait for that. So thanks for that, Kristen.
Thank you.
All right, I did see Crystal come on, so turn it over to her for some network updates.
Thanks, Kristen. Good morning, everybody. So I'm going to go over some general network updates. Again, these remain very similar throughout the previous IBHS webinars. So just some reminders. This first slide just is a breakdown of our team and your specific network management specialist by county, as well as our contracts and credentialing person, as well as our claims resolution specialist. So you can feel free to reach out to any of us with any questions that you may have regarding contracts, enrollment, credentialing. That's what we're all here to help with. Billing usual and customary. Again, this is a reminder where we're asking providers when submitting claims to use your usual and customary charges versus your contract amount. This is important in the event that there are rate increases. Sometimes those increases will have an effective date prior to the submission of your claim. So with those higher billed amounts, we're able to go back and adjust those claims that are already on file without having to ask providers to resubmit those with that higher billed amount. We would be able to then just manually automatically sweep those claims and adjust without having providers to do any additional work. If you have questions, you can reach out to any of us regarding usual and customary billing. Just some billing reminders. Again, try not to bill using the member's home address or any location that is not listed on your fee schedule. All your fee schedules will have your appropriate rendering addresses as well as MIS numbers. Your contract will also list your codes and modifiers in a specific order, so just make sure you're billing using those contracted codes. Authorization codes can differ from what's listed on your fee schedule, so just making sure when you're billing that those modifiers are listed in the order that they show. For any corrected claims, we are requiring that you submit your corrected claim with the original claim number on them. We are still seeing some claims come in as corrected with that information missing, which is causing duplicate denials and not allowing those claims to process. And then for any Act 62 members and all members with a commercial insurance, claims do need to go through your primary payer first before submitting to Medicaid, who is always the payer of last resort. Claims resolution. So for any claims that you feel were denied incorrectly, you can call these through our customer service line. And these claims would be considered claim inquiries. When you're speaking to a customer service rep, you can see if they can submit those claims back through our SRA process or our service request application. That's sent directly to our claims team for review, and it gives specific information. I know there are times where our customer service may direct you to your network specialist, which is fine. We're happy to help, but we are asking that you push to have some of those service requests submitted because, again, those go directly to our claims specialist, and she can get a look at those in a very efficient and quick timeline, usually within 24 to 48 hours. Again, just some reminders regarding satellite sites and licensing. So IBHS licenses are issued regionally through the 4 regional offices. You'll only need 1 license if you have multiple services in one region, but you are required to get a license for each region if you're going across the 4. You will need your service description to include all locations under that regional license, as well as those services that are being provided at each location, for example, home, community, or site-based. A provider is required to submit 1 service description per each license. And if any of your services are changed or changing, an updated service description does need to be submitted to that field office for approval. And then once approved, if you could send that to us as well for our records. If you're changing any addresses or moving, please notify the licensing field office of that as well, because you will need to get that license updated as well as your MA enrollment. And MA enrollment is only required for sites that are providing site-based services. Again, with those moves, if anything is lapsed with enrollment, that can affect reimbursement.
Crystal, I just want to call out a question we had on our last slide, and I just want to make sure I'm accurate. Somebody asked if customer service is wrong or maybe has the wrong determination, what should be their next steps? My response was, and tell me if I was accurate, that they should just ask the customer service to submit an SRA that goes to the claims rep so that somebody else could look at it. And if they are having trouble getting that accomplished, they can outreach a network rep, to help move that along. Is that accurate?
Yeah, that is accurate. Yeah, the SRA process is great. And again, like I said, it does go directly to our claims specialist. So she's the one that has all of the access to the behind the scenes stuff with claims. So that stuff will go directly to her for review. And like I said, she does get those accomplished usually within 24 to 48 hours.
Thank you. Sorry to interrupt, but I thought just get it out now.
Yeah. All right. So for provider expansion, so any providers interested in expanding services are encouraged to submit requests through our standard process. I did list our interested provider inbox below. If you already have an interested provider application on file, we do track all of those. Everything is saved and we do keep them on file. So no additional information is needed. If an application was declined, you would have received notification already from Magellan. Applications are reviewed on a monthly basis, and we take into consideration county-specific needs, current capacity of our current in-network providers, and service availability. Decisions are also made at the county level and may change over time. So that's why we're still reviewing those monthly, and we're working closely with our counties to determine those needs. For the IBHS group process, that would be for adding any IBHS group, EBA group, or both. Similar to the interested provider application, you will go to our inbox. We can send you an application. You'll fill that out for us to review. We do ask that for this level of care specifically that you submit your service description containing where the services will be held, the population that you're going to be serving, clinical model of the program, the number of groups and size of groups, just that specific information. We do ask that that's included in your service description. For provider expansion or changes, so this has been a trended issue where we are still seeing providers that are moving locations and either letting us know after the fact. And again, this can cause some issues with reimbursement because we do have to make sure that your address and everything is updated in our system, as well as verifying that MA enrollment. But if you have any changes or expansion, we are asking that you reach out to us directly and let us know as soon as you know that you're moving, so we can work with you to get everything changed on our end, so that this doesn't lead to any claims issues with billing for services that necessarily wouldn't be covered at that new location, and again, may not being able to verify that enrollment. This is just an information slide about our Availity contact information. They can be reached through e-ticketing 24/7. They do have chat available as well as their phone number and times listed that they're available. Some more network reminders. Credentialing is updated every 3 years, so providers will be directly notified by our credentialing team about 6 months prior to your recred date. We do ask for providers to make sure you have your information, mailing information updated in our system. If you have multiple locations, please go into the website and make sure that you have your specific rendering address, but then have your mailing address updated to the appropriate place you want your mail to go to. We've had providers in the past who have a similar mailing address to a rendering address, and they're missing these recredentialing applications and allowing recredentialing to lapse. It is a longer process if the recredentialing does expire, because then you'll have to start from the beginning. So again, please just go through and make sure that all of your locations have the appropriate mailing address so we can get those applications to the right person. For Medicaid enrollment, that's due every 5 years for revalidation. That date can be found directly on the Promise website, and we're encouraging providers to know those dates because you are responsible to make sure that you re-enroll as needed. This includes all enrollment locations as well as different provider types and specialties. And again, without enrollment, providers are at risk of not being reimbursed. When referring or transferring a Magellan member or family to another provider, please make sure that that provider is contracted and in network with Magellan. Magellan's policy related to non-PAR requires that all providers try to use and exhaust all in-network options first. And to initiate a referral for a member or family to an out-of-network IBHS provider without talking to the family can cause some unnecessary delays in accessing services, as well as offer some confusion to those families. So please include Magellan if you are considering a referral based off of no in-network availability.
I think that was it, Crystal. Thank you. I didn't see any other questions come in, so thank you again as usual.
Thank you.
All right. And we're up to clinical updates and reminders. So we have some good things to report. We have some new team members for Magellan's IBHS team that you might start hearing and seeing from. Some of the new members they're still in training, but you'll see them slowly get on. So yeah, here's some of our new people. I asked them to come on camera for a hot minute, so I didn't give them a lot of warning though. So our first new one is Barbara. Again, she's in training. There she goes. She's waving to you. And she's kind of filling in the Ashley Cummins slot. Carla Bruno is one of our newer care managers. She's filling in for replacing Sasha on the Somerset Bedford Kids Care Kids CM position. So again, starting to see her review some packets and get involved with some of her other stuff as well. No changes here, but I wanted to give you the opportunity to see if they were around. Michelle, we have two Michelles on a team of, yes, of a team of like 5 or 6, we have two Michelles. So there's Michelle G. And we have a Michelle B, one of our BCBAs. Megan, thank you, Megan, on camera. She's another one of our BCBAs. Tara Benson is here, I believe. And Ashley is here with us 3 days a week. So she will jump on. I don't know if she's on yet. She had a commitment too. So thank you again for patience as new people come on and leave. But hopefully you're getting obviously consistent help. You guys always know where I am, and I know people outreach me. So if there's ever any issues getting in touch with somebody or not being clear who your point of contact is, please let me know. But hopefully you'll hear a little bit more about some caseload reassignments and stuff coming up as we get Barbara and Carla acclimated and trained fully on their caseload. So thank you, team. These are just reminder slides. We have our treatment record review or clinical measurement tool that we are doing every quarter. Not every provider gets a quarterly review. Generally, you would be reviewed twice a year if you have 15 or more members. So we do take a random sampling of packets, our current packet on record for a member, and look at the packet compared to the tool. We have shared the tool. So if you clinical director or somebody wants to be able to look at that, we're absolutely able to share that with you. You just outreach your care manager so you can see what the tool looks like. And a lot of providers do use that as a, self-audit tool. So we encourage that as well. We'll talk about what next steps. So after the cumulative review comes in, if the score is 76 or above, that is considered a passing score. You will get a letter that shows that your agency was reviewed. Give you a code for the members that we did review so that you can outreach to Liz and Liz can tell you the specific member names. We just didn't want to share that amount of PHI that way, but you can certainly know which members we did review in their packets. And we do offer some feedback as well. Again, some areas of strength, some areas of continued opportunity, even with passing, but no action plans or anything will result if you have a cumulative score of 76 or above. If you had a cumulative score of 75 or below, you would get an outreach and a response and notification from our QI department, and they would walk you through some of the next steps. And it's an encouragement to just look at some of those areas, offer a plan. Sometimes we've had all kinds of issues discovered as people really looked closer into that to something from a provider's electronic health record is not transferring into the packet, and therefore you thought you were sending in this piece of critical data or information, and in fact we weren't receiving that, so we were absent of that sort of data point. So some people have figured out that. Some people have said, oh, if I change my template a little bit, it prompts the clinicians to ensure that we do hit all of these areas. Again, some of these are regulatory and some of them are clinical best practices or things that Magellan is looking for. So not all of them are regulatory either. So it's a combination. If you look at the tool, you probably can identify which ones are more regulatory than others. So we walk you through that action plan site. We offer those providers an opportunity to meet with the QI and clinical team to ask any questions about next steps and go from there. Again, it's an opportunity just to really sit down and look at what opportunities exist to make those changes, edits, enhancements. There's always some additional opportunities, but you have plenty of chances also to have further conversations and dialogues with the care manager and the QI department as well. These are, so we're just starting into our Q3. And so we started doing this is sharing which of the providers are getting the Q3 treatment record reviews for the quarter. I used to, when this was starting, it was pretty providers who start with A through I, and then providers that start with J through Z. But as some providers have had action plans, we've actually extended the time in between to allow further time for implementation of changes to go through before they get re-reviewed. So it's not quite as simple now. So instead, we've just sharing who they are. So they might look like they're A through I for this quarter, but there's a few additional ones depending on how providers fall in that. So that's that review. I also wanted to call out that the Somerset Bedford providers for IBHS will be starting this process, TRR process, in Q4. Again, because we split the providers, you may or may not be having a review in Q4. It may be Q1 of next year, but we are starting this process. If you're a provider for Cambria as well as Somerset Bedford, we would be putting you in together with that fold. So you would have all of your agency, all of those counties reviewed in one quarter. We wouldn't split them out. Okay, so hopefully you got a chance to look at that list. In fact, the end of Q2 is in process of coming out. I will share that. So in the next week, all of those letters will be coming out for you as well on who was able to pass and give you that opportunity for feedback and opportunities there. So keep a lookout for that in the next week from the clinical team or the QI team as well for the end of the Q2 results. Just reminding people again, it seems like the team has shared there's some new people that have been hired or new responsibilities from different providers. This is a tool that has only come out in the last probably 6 months, but feel like we refer to this a lot. And it's probably a good tool, especially for new people doing new positions or covering what there's PTO and such, which is an authorization request checklist. It goes through all kind of the different processes, and there are many in IBHS of how do you submit it? Do you submit it online? Do you submit it via fax? What are the documents that are required? So that's always a good first check to say like, hey, does any of what I'm asking fall in any of these categories? And then go from there if you have any questions. It is posted on our IBHS provider website at the top. It's one of those first few resources at the very top. So really encourage, again, if it's not you, as an administrator, then your direct staff that submits packets and stuff, please let them know that this is a resource. A lot of people are using this as a checklist for themselves, that not submitting it that way, but it's a double check to make sure that everything is appropriately submitted so that it can be reviewed thoroughly. We still have a few questions or coming up about the initial assessment requests. So that is a separate TAR called a registration only. We don't do an MNC review on those. It's a shorter TAR, looks like this. I think some people, when we made some updates to the other TARs, thought that this one didn't exist anymore. It does still exist. The process still exists. So please make sure it didn't get changed though. But please make sure you're using this for any initial assessment requests. Again, this is one of the ways we track new kids that are coming into IBHS service and report out to the state. So continue to use this. If you don't, unfortunately, you will have some billing issues because the modifiers are different. And if they don't line up with the authorization, they will result in a denial. So we obviously want to avoid that and give credit where credit is due. So please make sure that your staff is aware that this process still exists and there is a separate TAR. Again, it's on the IBHS provider website as well, or in our forms section. The other thing I'm pointing out is that when we did make all of those updates to the regular service TARs, we had probably one little ideation that came out afterwards, and we updated it again in November of 2025. So it hasn't been updated for a bit. And one of the things that we did do is, and I don't know if you can see my cursor, but there's this horizontal line here where it combines the space for your BHT lines, so that you can put your total units and your start and end dates all cumulatively. That's how the auth will show. On the right-hand side, under the blue sections of the assessment, that's where there's more separated lines where you could draw out things like, oh, this is the dates and the areas for the BHT in school, in daycare, in the home and community. But the the left side with the gray, that's the section where you want the total units, the first start date of BHT, the last date of your BHT, that's all going to go together. But it's important that you also use that breakdown on the right side where I put these 3 arrows in. If you use, again, where this red arrow is, if you use the 11/1/2025, it's a little bit more scripted for you. So please make sure your staff is using that most updated. Again, it hasn't been updated recently, but we're still seeing some of the old ones, and I think it's leading to people not filling it out with the breakdowns that we are really looking for. So again, this is also posted on the IBHS provider website. So you can easily grab this form and make sure you have the most current. Just a quick call out, please make sure they check off whether it's an initial or concurrent. It helps streamline the care manager's review and process. On that TAR, one of the things we did add was whether this service and these hours are being increased, decreased, if this is a new service request, or there's no change from the previous hours. I think that's a super important thing for the clinical team as a whole to understand when they're making the request, consciously knowing. So it shouldn't be anything that's not clear. Is this a request if it's concurrent? Are you adding this as a new service? Are you increasing it? Yes. If I had school BHT before, what did I have before? Is this an increase in that number of hours? It stays the same, or a decrease? Again, that helps expedite the review process and makes it all crystal clear. Make sure we're all on the same page, that you see it the same way we see it. It's just another check. Also, to double check the accuracy of the settings being recommended in the assessment. The assessment recommendations are the driver of everything. We've seen a little bit more confusion or inconsistency between the assessment recommendations and what we see in the TAR, or not seeing things called out in the TAR that we see in the assessment and or in the treatment plan. That just makes us start to question and doubt whether we're reviewing it accurately. We ultimately have to go with what the assessment says, but it always makes us feel better that we're understanding what you're truly looking for if every document has the consistent recommendations on settings. Specifically seems to be the biggest area. Here's that piece of the TAR where we talked about the increase and the decrease. This doesn't relate to the written order. That's something I didn't say just before. This relates to what the services were recommended and approved for the last time or currently until this new one comes into play. So it doesn't reference written order. It's what the service delivery was approved for the last time. If you requested and got approved for 40 hours per month of BHT in the home and community, and this time you're asking for 40 hours, that is the same. And again, it's based on more the assessment and the approval of the previous authorization. This is just a reminder of how to complete that left side of the TAR where we're combining all of your units. So if you have a crazy breakdown of BHT in all different settings coming and going with the summer and starting of school and all of that, we want that total number of units. And we want the first date that you're starting, let's say a BHT, and the last date that you're looking to start the end date. So if there's a gap in between and things like that, or you go from school hours to home hours to school hours, this is really looking for that big auth. This is the auth that you would see in our system once it's finally approved, those total units and the entire auth timeframes. Again, just a reminder, we can go back 2 business days from when the packet is submitted. So please keep track of that sort of timeline. And we do have here that there's a maximum of 6 months, except Somerset Bedford does have an ABA authorization for 1 year at this time. So I make sure I put that caveat in there as well. And the right side of the TAR, again, the reminder, breaking down the hours and the service by setting, checking off whether this is new, increase or decrease, and you can utilize the right-hand side to break down those time frames so that you're getting the units that are appropriate and not a full span of units that you may not use because they're not going to school in the summer. So I don't need full 6 months of school BHT units. I need this date to this date, there's a gap, then I need this date to this date, and I would total those units together. This is how I would look at it with the auth calculator and how it all comes together into that final one. So again, sharing these slides with people who are figuring out units, creating the TARs may be a really helpful thing for them to sort of relook out, make sure that that's what they're doing, to just again avoid any confusion. The care managers and even some providers have said that these revisions to the TAR have been helpful to make sure everybody's sort of on the same page. So I continue to ask that, we continue to utilize that. So somebody's asking, I'm using the correct version, but don't see initial on the TAR. So it might say pre-service review. Sherry, do you see that? Pre-service and initial. And maybe a care manager can pull up the TAR, make sure I'm using correct language. I think that was my reminder about checking off whether this was an initial request versus a concurrent. Okay, somebody will let me know. You guys can come off mute and let me know if we're talking the right language. I think the word might be pre-service review, similar to how the wording is in Availity.
Yes, it's pre-service request.
Thank you. Sorry for that confusion. I could correct that language on this slide as well. Pre-service, initial. Unfortunately, we use those kind of a little bit synonymous. Some of the assessment observations that we wanted to call out that are helpful to continue to add if your agency doesn't have are the dates of the observation. When are these observations happening? Are they happening, sooner than later? Giving that time context can be very helpful. How long are you observing? Very different, if you're there for 15 minutes, a half hour, if you spent 3 hours, it may tell us, we didn't have a lot of time to make an observation of certain behaviors, or we were there for quite a long time and we did see X, Y, and Z, or we didn't see X, Y, Z. What's the setting? So not just sharing what it is, but are you at the preschool? Are you in a community park? Are you in their home? Sort of painting that setting of exactly where you are and any data on the observations. So hopefully you're using those observations not to just write a narrative, but also to use some of the data of, we were targeting this behavior during our observation. We saw that occur. We didn't see that occur X number of times. Here's the intensity, and sharing some of that data observations is good as far as the assessment data and information. It helps paint a good picture and a comprehensive picture for the team that's reviewing. few point outs for data specifically. Baseline and current data should be measured the same way. It's obviously really hard to assess progress when the baseline and the current data aren't measured the same way. You can't truly tell. We have had a few providers ask us, like, the BCBA or the supervisor saw, like, oh, that isn't in the same metric, and we needed to change it. Usually we'll see a note in the packet that says, we had to make an edit and realize that it wasn't being captured the same way. We made this change to it. So that's fine. Obviously, we want you to catch that and make that correction as well. Clearly, being able to assess the baseline to the current is obviously going to be the best indicator for that type of progress, and that there should be define the time frame measured within. So again, we kind of talked about it in the last slide. How long is the session? So if you say per session, is your session, again, 30 minutes? Is your session 4 hours? So defining that more than just per session is obviously more helpful in understanding the data as well. Progress should be reported over a period of time. So sometimes you're using some assessments and taking kind of a snapshot in time. Obviously, you're presenting 6 months or a year's worth of data, ideally from the last, services that you've been delivering. So looking at that as well, cumulatively, is helpful, even if it's, a 2-week period. Progress obviously should be monitored over a time period. And it should be reported based on behavioral data changes. So sometimes there's a little bit more of a narrative, but the data doesn't always reflect what the narrative is saying. So we really want to see consistency between that narrative and the actual data itself showing that there was a change, a progress. If there wasn't, obviously, why? So provide an analysis of the data. You guys, having graphs and different things is excellent. You want to make sure that we understand it the same way you and your clinicians understand it. So providing, again, not lengthy, but some type of analysis to say, yeah, this data, this graph is showing this. Just to make sure, again, we are all on the same page. There's no opportunity for misinterpreting what is seen in the packet. So those were just some of the things that some of the team was pointing out. You guys liked this before. I don't know if it's the same group, but I put a couple in here. So not necessarily errors. Sometimes it's just issues. Sometimes it's things that we may offer feedback on, etc. So I put a couple of these in instead of just blah, blah, blahing and not having the examples. So there was this ABA treatment goal. Well, Beth will decrease socially inappropriate behaviors to 3. It should probably be 3 times per hour over 10 consecutive days. And the socially inappropriate behavior definition was, and you can read that, the issue or struggle we have with this would be an operational definition. It should be observable, measurable, free of assumptions. It is very challenging to be able to easily identify rude, bossy behaviors showing off. That's hard to touch, that's hard to quantify without further definitions. So any person who's trying to gather this data, it's a little bit subjective to be able to know, oh, that's what I'm looking for. Check, I see it. Check, I don't see it. It's not observed. So as you review some of the documentations, taking into effect of whether these definitions are operationally defined and very clear so that anybody can track this data and that the data is then reliable and consistent across staff. Here's another random one. We have assessment recommendation that says BHT ABA is recommended for 135 hours per month in the school for 6 months. And the request on the TAR shows the request is going from May 5th to October 31st. Any idea what the issue may be or the question that comes to mind? Our question mark would be what's happening during the summer months? This date spans from the end of the school year to the beginning with summer included. What's happening? Is there ESY in there? ESY is usually not a full summer. So we start to question what's happening with that. And so the bottom part would be the better opportunity, which is carve out, nope, school BHT goes from 5/5 to 6/10, and then it restarts August 31st to 10/31. Being able to carve that out. Again, it eliminates more questions in our mind. And also, again, you would get a lot of extra units that you wouldn't utilize. And that, you know, if we're looking at the number of units used versus approved, it would look inaccurate for you guys as far as utilization of services. I'm assuming a care manager will look at the Q&A and tell me if I need to stop and say anything else, because I'm not looking at it right now. Can you spot this error? So barriers in treatment, some of the ones that we may hear. Jenny doesn't understand the seriousness of her behaviors. Jose is not verbal. Jack is aggressive. Mary has an intellectual disability. These are things we've actually seen as barriers in treatment and barriers to progress. Really, the question is, what's preventing the treatment team from making progress on the members' treatment goals? Some of the things we see here as barriers are actually the reasons and the things that the member is being treated for and to try to address. So I have this other slide. Some of the things that may be preventing some progress from happening is medication inconsistency. Sometimes they're on the medications and we see a positive behavior trajectory, and then all of a sudden they're not consistent, and then there's a change in the behaviors. So it's not accurately even assessing the treatment that you're providing. Maybe the parents are not on board with some of the interventions, so there's a lot of inconsistency. That's certainly impacting the impact of your treatment, right? Lots of canceled sessions, inconsistent routines, different expectations across settings. But things like this member has an autism diagnosis, they're not verbal, they're physically aggressive and attention. I'm sure that's an issue, but it's also a lot of the reasons that they're in treatment and that the treatment goals revolve around. So really encouraging the team to think honestly about what is preventing progress from happening on each of those treatment goals is really what to look at. And then obviously, once those are identified, what's the plan to help address it? Is there something you can do differently? Would you change your interventions to ones that the family feels more comfortable doing, is more able to? How are you going to address the canceled sessions or the inconsistent routines in this coming authorization? What's going to be different this time? Or, you know, a plan to try to change some of that and make that and push that treatment forward. Okay, another one, we have this goal of reducing impulsive behaviors from 5 or more incidents per session to no more than 1 incident per session across 4 consecutive sessions. There is an operational definition of the behavior. And then there's the data of impulsive behaviors occur 3 to 5 times per week, lasting a few seconds to a few minutes. This is not an uncommon example as well. The struggle that our team runs into is seeing differences, big differences in understanding what this looks like for physical aggression, which certainly has some definite safety concerns attached to it, right? Versus a yelling behavior. Sometimes lumping all of the things that are sort of even high risk safety related with other things can make it really challenging if you're not presenting data. If you're presenting data in this big lump, which would be the impulsive behaviors, it's hard to tease that out on the severity of all those behaviors. So being able to pull it apart or offer data at least specific for certain things and looking at how you're putting your groupings of behaviors together, that's a consideration when you're sort of reviewing these treatment plans. So it helps the reader better understand the behaviors, the needs, the progress, if it is more broken down and we have some more specific data on some of those higher risk behaviors. So just something to be aware of going forward. Just a reminder about the interagency service planning team meetings. So Magellan has the requirement that whenever a BHT or BHT ABA services are being recommended or requested in a school, a preschool, a daycare, a summer camp, after school setting, any of those structured type programs, that an ISPT meeting is required by Magellan. And in the packet, we require a summary of that meeting be submitted for review. And the meeting summary should detail what was discussed. So how is the member doing? What are the ongoing needs? Do we see some areas of progress? How are we going? How is the transfer of skills going? Is the staff struggling with anything specifically? Have they learned certain skills? What additional skills do they still need to do? What's the plan to transition out and have this person be more independent in their natural supports? So having BHT in school for the rest of their academic career is not the role of the BHT. So if we've achieved a certain level or we're getting close to that, what's the long-term plan? What have we figured out that we can pass on to the school and the IEP team to see what are the ongoing needs if we're not here to do some of that support? So that's a really helpful document. It also shows active work on that coordination and transfer of skills. Sometimes we're seeing not the school invited, which is a problem. So it's sometimes just with the parent. This is your opportunity to say, you know, this is a requirement school. We need to preschool daycare. We need to have this meeting. This is a really important carve out to have that conversation of, hey, this is what this kid's accomplished. This is what you've learned. This is where we still need to get to. It doesn't have to be a lengthy meeting, but it should be a really good checkpoint in the overall process and encourage the conversation. So the school, that staff, somebody, principal, social worker, teacher, LEA, somebody from that school would be important to have. And the guardian obviously is still an important part. They should be hearing this conversation. They're going to be the ongoing advocate for these kids and their support needs for many years to come. So it's important that they hear and understand this language and your role as well in their child's success. We've shared this before, but some of the good questions that might be helpful. Again, we don't have a template that we have designed at this point for an ITM. However, I've seen some providers take it upon themselves to develop their own template to share so that each of their clinicians is doing consistent questioning, that they get the right information and capture it the same way. So I kind of rattled off a bunch of these, but about, you know, what strategies are working, what are the ongoing needs, how are those skills being transferred, what's our plan to titrate out, etc. So these might be things to offer to your staff, or if you design a template yourself, to consider these questions as part of that conversation. Because we have this requirement, we did make an adjustment to our place of service codes. So that 03, we are looking for school, daycare, preschool, after school. We still get some questions about this, and I'm sure, you know, Crystal's still on. Again, it relates a lot to the ISPT meeting expectations. In reality, when you write things in the assessment, the more specific you can be, the better. So if it's a preschool, just write preschool. Honestly, does it truly matter in the larger scheme of whether it's a school or a community setting? No, except if, as long as you understand and we understand that's the preschool or the daycare where the services are being delivered. Everybody's okay with that. And that you still know that the expectation is in that setting, school or community, that you need to do that ISPT meeting. And I will share, because I know we've had a couple questions, probably some newer people. The 97156 code, which is the BC ABA code for, which is not an auth code, it's a billing code for family adaptive code, parent training, caregiver training. It's called all kinds of different things. We do know that you are not allowed by the coding from the state to do a school code for that 97156. However, all of the BIM codes, and I know even in a lot of the primary insurances, they're pretty strict about saying that that code belongs to the parent or guardian. And the BIM codes and with OMSAS collectively, when IBHS was coming on this horizon, said we really want any caregiver. So that's caregiver during the day might be the school or daycare staff, as well as the guardians, the parents. We want to make sure all of those people are getting the support and the training to transfer those skills. So we want to support caregiver training in a school setting if that's where you're providing support. So if you can't bill the school, you can bill it as a 99 place of service code.
Kristen, there was another, since we're talking about the billing codes, there was another question from Tina regarding the TAR only showing HO modifiers and not having HA modifiers. I thought originally she meant on the regular TAR and explained that the HA would be on the and registration TAR for initial assessments, but she was saying sure they're referring to the HOHA because they're getting claim denials. And I did explain that auth codes are different from claim codes. And I could share that via email, the auth codes versus claim codes, but I'm not sure if there was anything additional that we needed to.
Yeah, we have bucketed codes. So similar to what I was just saying with this 5.6 code, instead of authorizing each claim code, we put them in buckets. So our BCABA, for instance, has like 6 codes that you can bill under. So the HOHA is generally like, let's say the BCBA is the clinician that's actually delivering the service. We only authorize one BCABA code for all of the different tasks, for the different credentials, whether it's a BSL or a BCBA. That's what the auth is going to show you. So we don't authorize the full modifiers. You won't see all that. You're just going to see the auths, and then yes, they get bucketed, and in that bucket are about 6 different codes that delineate the clinician, if they're licensed, if they're BCBA, right? All of that based on your contract. But you won't see that in the authorization. If you're getting denials for something that you're not figuring out, again, what I often will see is a denial based on the fact that you were supposed to have an initial assessment, which is an HA, starts with an HA modifier, but you build it under an HOHA. Well, in that time frame, you were technically authorized for an assessment, so it should start with an HA. But if there's specific questions, which it sounds like there may be a specific claims question, we can certainly look at it very much more specifically, or ask for customer service to look at it, or the SRA for the claims specialist to do so. But do we think there's anything else on that line?
Yeah, so what our problem is that we have authorization that is for the HOHA, which is bucketed, as you said. And we submit the claims for the LBS or the BCBA. When we submit the claims with the HOHA modifier, we get a denial coming back. We call in to customer service to get it reprocessed. And the representative tells us that our authorization only shows an HO modifier and that the claim has to match the authorization exactly, and they will not reprocess it.
And I've honestly addressed a bunch of that. So our customer service reps serve lots of different contracts. So you're correct. That is not an accurate statement with IBHS that the auths match the claim. However, claim system does know that, so that makes me think that there's obviously a different reason why those claims would be denied. So, Crystal, are you hearing all of this? Do you have a suggestion for next steps? Would it be an SRA? Would it be outreach to the network rep to look at it a little closer?
Yeah, I think when in doubt, always go the SRA route, because again, Taylor can view all of that behind the scenes stuff.
So I have asked for them to do an SRA, and the representative won't. Because there's no point in submitting a ticket when it does not match the authorization exactly. So there's no point in submitting a ticket to have it be looked at and reprocessed.
So in that scenario, are you saying that the authorization needs to be updated?
So
No.
they're saying that the claim does not match the authorization exactly because the authorization shows an HO modifier only and the claim shows an HOHA. And I explained that it buckets and the representative just argues and refuses to submit the SRA.
So if that happens again next time, number one, if you could get their information, and then feel free to either send it to myself or whoever your network rep is. But also you can ask to speak to their manager, because really that they should be submitting those for review from our claims team specifically.
Okay, I spoke with one representative who did submit the SRA and they did come back and get reprocessed and paid. This specific one, I think, I want to say that this one did speak with a supervisor and wouldn't, even the supervisor wouldn't.
Okay, so if this were to continue, if you could let me know what the specifics of who you spoke with, we can escalate that to help with training purposes.
Okay.
Yeah. And I've done that before.
Okay, thank you. And I have a follow-up question on the 97156. Since it cannot be billed under school, if it is billed as school for commercial, are we allowed to change it to 99 to submit to secondary?
Crystal.
So I would have to check. I believe that code is that place of service 99 is allowed for that code. Again, that would really just have to match what's listed in your records. And this is really just for auditing purposes. So as long as your notes reflect what's being billed, I don't see 99 being a problem.
Okay, so for clarification, if it's billed, for instance, to commercial IBC under the school location, and then it comes back as paid, and we submit it to you as secondary, we are allowed to change the location to 99.
Correct. So the three things that we look for when you're submitting secondary is number one, the build amount matches, the member information matches, and the build amount, the member information, and the data service.
Okay, perfect. Thank you.
Yep, you're welcome.
Can I ask a follow-up question about that? If the commercial plan denies the place of service school for training, and it's like a denial of like not place of service, not covered or something like that, would Magellan cover that as secondary?
That I would have to follow up with our claims team on. Without specifics of the EOB, it's hard to really answer that.
Okay, thank you.
Sure.
Right. Thanks, Crystal. Okay. This has come up a little bit of times. I know Avality can be quirky at times, so things aren't working, especially as members' names and finding them a certain way. So I always like to remind you guys that you can actually view authorizations a few different ways. So you may be used to doing a name and they have a hyphenated name, and that's definitely throwing off probably those results. Or if they happen to have an authorization or an account in 2 different counties, sometimes it's pulling the wrong one. So there are things that you can do differently. One is to add the county abbreviation in front of your Medicaid number. I would suggest always doing that if you're looking up by Medicaid number, always adding, so if it's Montgomery County, the MNT before the numbers. That ensures that you're pulling the accurate county. Sometimes, again, if they had it in Bucks, and they're termed, our system is pulling up Bucks first and saying it's termed. And you're like, no, it's not, they have active MA. But if you put the MNT, it'll pull up the Montgomery County request for that kid and it should show that it's active. And if it's not, then you can let us know. We want to get our system updated. However, in the meantime, you can also look up an authorization number. And as you know, concurrents should be underneath the same authorization number. It shouldn't change. So feel free to pull up the authorization number, and you can also pull by your provider ID or your MIS number. You can search and get the whole list of all the members authorized underneath that MIS number to look for it that way. So those are some of the quick things I wanted to say. Also about Avality, right now, some of you were having that issue with attachments. It seems like depending on how something is saved is indicating an issue with the attachments. So there are providers out there that have had no problem, ironically, getting their attachments through and submitted through on Avality. The rest of majority are having to fax their requests for now, and we're doing our manual auth entry, etc. The IT has said they know what the issue is, and the fix is supposed to happen this coming weekend, August 1st. So we're hoping, knock wood, I'm going to walk in Monday and see that has been eliminated and that we can go back to getting the attachments happening. So just so you know, the estimated plan of that change we have this week to get through, and hopefully over this weekend the change is going to be put out, and hopefully by next week we will be able to get those attachments loaded and go back to our normal processes and only fax when necessary or needed for depending on the process. So that's the Avality update that I have. We actually have had this come up a little bit, so I wanted to also remind people that there is an IBHS regulation 5240.7 about coordination of services, and it specifically talks about that the agency should have a list of community resources that are available to families. So this is what it says logistically, but we know that a lot of these members and families would really benefit from services supports beyond just IBHS or in conjunction with, right? So having that list of some local resources is super helpful. We have a lot of things on the Magellan of PA website, or we have links to the county who has a lot of those additional resources. So even if there are things outside of behavioral health services, we often get a lot of questions about like home health aides, which isn't behavioral health, it's the physical health, but being able to know some of those resources and having that list for your staff, one is part of the requirement, but two, also really helpful in looking at the whole person and the whole child support system. So we're obviously willing to help fill in any gaps, but it is something that you should have at least some baseline of a community resource list and be coordinating with that. My last one for this time is the eligibility checks. I kind of threw this in, it's a little outside clinical, but we wind up getting looped in as a clinical team because it seems like maybe the eligibility checks aren't happening quite as efficiently, or the system isn't passing it down to the right people, because it seems like months later, somebody will say, oh, there was this issue. and we didn't know it. And I'm like, but it's been this way for months. Obviously, sometimes the system retroactive, authorizes, retroactively does some backdating on the Medicaid or something like that. And you can show us that, and that's fine. It does seem like, though, maybe that's not the case. So we want to make sure, again, just a reminder, I think I pulled some of this. Yes, I did, from the provider handbook. So who, go back and ask who checks the eligibility in our agency? How often does that happen? Are you keeping that hard copy? Because again, if on August 1st it shows that it wasn't active, and then on August 15th, it shows it was active on August 1st, and you have proof that says, no, look, on August 1st, I ran it. It said no. That will be helpful in you submitting a retroactive review and getting that approved so that we can go back and authorize it, because technically on that day, it did not show that. And then the bigger question, I think, is how does that get communicated to others? So if the billing department is kind of running those checks, what's the process to get it to the right people to talk about what the next step is? Is it a retro? Is it putting, an authorization packet to a different county that's necessary? Not realizing, oh my gosh, they changed to a different MCO. All that stuff. I think there might be a little bit of a breakdown in some of the agencies because of the amount of questions we get that are so far out from when that actual change happened. So again, just making sure you guys are getting paid for the services that you're rendered from the right people, and not that we have to say, no, we can't do that because of X, Y, and Z. So last things, and we have some important things in here. We did have in June our developmental norms, our first IBHS best practice webinar. Our doctors presented that. We had a large turnout. It was very successful. As of today, that training is posted. So it is posted on the IBHS provider website. I had a couple of people outreach to ask about whether that was happening. Yes, it took a little while. There was some kinks in the system, but I can confirm that as of today, that PowerPoint as well as the actual recording is posted on the website. And then the next one in September is the FERBS training. And I did check in with Chasey this morning. She's saying that the registration information for this one will be open the week of August 24th. So I'm sure our care managers will help and ensure that you guys are aware of that. But if you don't hear something by that point or sometime in that week, you can do an outreach as well and find out and ensure that we've got that. But put your calendar, put it on your calendar now so that you have it saved. Again, it's only from 9 to 10, and it should be another good training. So put that on your calendar. The next one of these will happen, which will be October 8th. So here's the registration link. We do not send calendar invites for these. We have a large group of people, and as you probably guess, people are coming and going constantly. So I make sure that you guys are aware of it in this webinar, and then the flyer at the bottom of our IBHS page, when it talks about the next ones, is updated probably in the next few days, and it always has the link and the registration link. So you can always go on there and grab the registration link, or if you forget to mark your calendar, go in there and check and get the date. But you can mark your calendar now that it is October 8th from 9 to 11. Some of our website resources, again, new staff on tap. I hear from a lot of people. There are some really good resources available for, again, training some new staff. The member handbook, the provider handbook, there's compliance alerts. So I put together a slide of all of those resources. Just a reminder, if you are receiving a written order that maybe you guys didn't do and it came from an external source and they haven't had services or they're in process of waiting for services, so it might be done by a developmental pediatrician, so we didn't get billed for that, it won't pop in our system. We're trying again to work with OMSAS in really taking a close look at that front door and how kids and how long things are taking between written order, assessment, etc., getting those. So this is the little bit of a gap if we don't do, they don't bill for the written order, and then waiting, which they can wait appropriately. They may not act on the written order right away, but just being aware that a written order exists and then kind of tracking when that assessment happens or the beginning of treatment. So if you have that information, that would be great to share. As far as the wait list, which has also sort of come up in some of our conversations with the state, our definition of a wait list is somebody who has a written order that does recommend this service. If you're just talking about somebody who has called, a parent that's called and said, I'm interested in looking at IBHS, and you put them on the wait list, we wouldn't necessarily consider that what is our pending IBHS wait list, because we don't actually know if that person's going to qualify or if that's the recommended level of care. They may be recommended for outpatient. They may be recommended for family-based, something higher. So if somebody has already had an assessment or written order, that does recommend this service and is trying to secure that service treatment, that's the person that we would consider somebody on your wait list. Obviously, you can do as an agency what you want as far as if we ever are looking for what your numbers are for wait list, that would be what we would be looking for. And if you can help those families who don't have that, we've talked about that before, if you can help get them a written order, or refer to them somebody on the access survey that is available to do a written order, help them take that next step. If you have availability to do an initial assessment and you tell them, the families up front, like, hey, we may not be able to staff it, but it might be helpful in finding staff and in getting services if we are able to complete the initial assessment. If the family's okay, initiate that. As you already know, it is a lot easier to know and to ask providers if they have availability when you know exactly this prescription that you're looking for. We're looking for this number of BC during the day, during the after school hours, versus do you have availability? That's a very broad question in this service level, as complex as it is. So we do try to help the families move that system along as best they can. Again, the provider manual, I wrote down some of the things that we even get asked these questions as well. A lot of the information like this is in the provider manual, especially like retrospective reviews. There's a lot of good information there. So again, training new staff, this is a good resource to start with, or sometimes it's all you need to get the answers that you need to keep moving on whatever you need to have done. Also want to alert you as you're starting sort of next school year that we do have this caregiver FAQ, which we worked with our providers on to sort of do like myths versus fact, to support the conversations with our providers about what services what's in scope for this service. Can you do this? No, that's not something we're supposed to do. What's our role? It helps reinforce the role, the expectations. So this is something that you may want to share if it's the first time you've been working with a daycare. Say, hey, this is a tool we use so that you're aware of some of the things we can and cannot do. Or I bring this to the ISPT meeting and I use this to help in our dialogue. Just another reinforcement on black and white that providers have said has been helpful in that dialogue with schools, even caregivers, honestly, even the guardians, etc. It's posted on our website as well. And then if they're starting to submit online authorizations and struggling with different things in availability, I use this all the time. This is a really helpful tool to have some nice step-by-steps and some visuals of like, why isn't this looking right? How do I view my authorizations? A lot of those have some really quick tips to walk you through the process. Again, if it's somebody new or filling in, here, use this. This is a good backup. So want to make sure that's people are aware that that's there. Looking, I do see another Q&A, but I'll check in. Michelle or anybody, do we have anything outstanding that we may need to cover? I haven't been tracking it.
I'm not seeing anything else.
Okay, so you guys were able to address any questions and or we talked about them already, right?
I believe so.
Okay, well, let us know. We're here. We're not going anywhere. All right. Well, I appreciate it. I know the middle of the summer is not the easiest time to carve out some time, but hopefully, again, you enjoy the rest of your summer, get a little bit of a break and breather to refresh and renew for our next school year. And again, the network team, clinical team, we're all here to support the work. And have a great rest of your summer. See you guys in October.
I do have a question. It's not kind of related to secondary authorizations, but it also kind of is. It's more for submitting claims to Magellan that have a primary admin denial, but have a Magellan authorization.
Mm-hmm.
So we have always been instructed that we mail the primary admin denial along with a claim from each set of services into Magellan, certified mail, so that they are signed for. And then we wait until Magellan processes the claims. And then we are able to bill Magellan directly as the primary. And that has been our practice all along. But recently we just did this. And when we called to follow up on this set of claims, the representative told us that they never received them, but we have the documentation showing that they were picked up. So according to the representative, those claims aren't in Magellan's system. Now we're looking at timely filing for the remainder of the claims. So I guess my question is that workflow still the best practice? And how do we move from here to get the claims that we already sent reprocessed without them being timely filing or duplicate? And how do we get the claims that are timely because we weren't able to send them processed without them being denied?
Tina, if you have your tracking information, and we listed Taylor Florence, she's our new claims specialist. Her email is listed on these PowerPoints. With that tracking information, that can be sent directly to her. She has direct access with our claims team in St. Louis, and they can find out where that issue is. It's always important to reach out and let us know when these things are happening, because we do want to try to avoid that timeliness.
Okay, so can I get a copy of this PowerPoint?
Yeah,
So
Kristen, everything gets sent, correct?
everything gets posted on the IBHS website. If somebody can post the actual address, I'm going to reshare the network contact just so you can see it now.
So who am I looking
So
for?
Taylor is at the very bottom, claims resolution specialist.
Hey, Kristen, can I just give my 2 cents of what we do for that issue? So we bill every 2 weeks based on our pay periods, and we have some kids who like have ERISA plans, so they don't have Act 62. We get the letter, we mail the letter, we wait 30 days. We still continue to submit on that 2-week cycle. Yes, the claims will be denied, but when I write my letter and send the letter from the ERISA plan, I put like, hey, you know, because the letter's dated, it'll say specific information about the coverage time. I will write in my own letter, can you please reprocess any claims that have not been paid due to Act 62? I have had an issue where I mailed multiple letters on the same day for different clients in different envelopes, and some got there and one did not. I just resent it because I kept a copy, and everything was fixed without me having to do anything extra than mail it. We don't send them certified because we were told don't send them certified because nobody signs for them. So I just put it in regular snail mail, and it seems to work out pretty good. But we continue to bill those claims so that there is a submission date within that timely filing of the 60 days, so that when Magellan gets all that documentation, they just look at it and go, okay, yeah, we have these, we'll fix them and reprocess, and then we get everything paid, no problem.
Okay, so just go ahead and send them regardless.
Correct. And I would say for the certified mail, just for tracking purposes alone, in the event where something does happen to be timely, that tracking information is 100% used in any appeals that are needed to override timely denials.
Okay. So I will reach out to her. Thank you.
You're welcome.
Right. Excellent. Thank you all again. Have a good rest of your summer.
Thank you.
Thank you,
Kristen, have a
Thank
great day.
you.
Bye.
Thank you.